Hello, and thank you for tuning into today's presentation. My name is Kashali Roy, and I will be discussing our project titled Empowering the Anti-Racist Physician, which is a quality improvement proposal that we implemented into our medical education curriculum over the 2020 to 2021 school year. Before getting into details about our course, I wanted to talk a little bit about the background of our project. Over the past couple of years in the pandemic, several gaps have been brought to the forefront of the U.S. healthcare and public health systems as health inequities are magnified amongst vulnerable populations. We recognize the need is great for health equity training amongst young physicians. Improving the understanding of health science systems among medical students will enable them to become more well-rounded physicians who can apply their foundational knowledge and improve the health of their patients and their community. In June 2020, a Health System Science and Community Service course was created as a required course for fourth-year medical students at the University of Texas Medical Branch. For this project, we implemented a module for students enrolled in the course to assess a variety of attitudes and beliefs on race. The goal of this project is to breed ground for the anti-racist physician. The module consists of 3 articles. The first of which provides knowledge on the complexities of applying race-corrected algorithms in clinical practice, the second of which demonstrated the impact of physician bias on patient care and health outcomes for non-white patients, as well as the last of which revealed how medical research, healthcare systems, and public health interventions might inadvertently perpetuate healthcare disparities. Students completed quizzes on the corresponding articles and completed a 14-question attitudinal survey before and after the exposure of the module content. 4 of the 14 questions produced considerable shifts in attitude in the comparing data sets. Compared to the pre-exposure attitudes, we saw in the post-survey that there was a 40% decrease in agreement/strong agreement that older physicians carry more implicit bias than do young physicians. There was a 3-fold increase in strong agreement that racial bias is common amongst physicians. There was a 43% increase in disagreement or strong disagreement that race categories in U.S. medical literature correspond to genetically and biologically similar populations. And 9% of a decrease in agreement categories, as well as a 29% increase in the disagreement categories that the U.S. has improved health disparities in the last decade. Although it was tough to point out statistical significance of Likert data, we found insightful results in comparative discussion. Further analysis of the post-survey results suggests that students affirmed the presence of an implicit physician bias, acknowledged that younger physicians may have just as much implicit bias as older physicians, that they see worsening health disparities in the U.S. over the past decade, as well as that they see race categories in the U.S. medical literature as ambiguous or inaccurate depictions of corresponding genetic populations. In conclusion, it's clear that the structural and interpersonal expressions of racism contribute to the social determinants and policies that create health disparities, as well as influence the diagnostic algorithms that may bias treatment decisions. Our goal to raise awareness of health equity in medical education was achieved, and we were met with positive feedback from the students. Ultimately, medical education that prides on professional development, culturally relevant content, and explicit dialogue on racism will strongly determine how we aim to reduce racial injustices and patient care gaps for the posterity of healthcare. Thank you for tuning into our presentation.